নাম্বার 3 HbA1c লেভেল, এটা কিভাবে দেখতে হয় তারও স্ট্রিক্ট ক্রাইটেরিয়া রয়েছে। HbA1c level more than equal to 6.5%, or if the patient have classical symptom of hyperglycemia like polydipsia, polyphagia and a random plasma glucose is more than equal to 200 milligram percent. In any one of these condition, if positive, the person is diabetic. Now, how we classify diabetics? Diabetes can be type 1 diabetes. It is commonly seen in children, also called insulin dependent diabetes mellitus, although the term is obsolete. Now, it is caused due to autoimmune destruction of beta cells, so that insulin secretion in the body is decreased. Number 2 is type 2 diabetes mellitus, is the most common one, seen in more than 90% of the diabetic population, generally late onset, more than 35 years of age. It occurs, the primary pathology is insulin resistance, that is the peripheral action of insulin is decreased. In the long run, the beta cell failure or beta cell destruction also occurs. Now, number 3 is specific type of diabetes due to other cause, like it can be drug induced, it can be due to the genetic cause, it can be due to the defect in the exocrine pancreas. Then gestational diabetes mellitus, it is seen in the second or third trimester of pregnancy. Type 1 diabetes mellitus, also called insulin dependent diabetes mellitus, basic pathology beta cell destruction in the pancreatic islets. Now, it can be again of two types, type 1A because of autoimmune cause, majority are type 1A, and some are idiopathic, type 1B. Now, here the circulating insulin levels are low or very low, and the antibodies are positive. These patients, because they are insulinopenic, the blood level insulin are very low, they are very prone to ketoacidosis. It's less common, low degree of genetic predisposition that does not run in families. Type 2 diabetes mellitus, it is also called non-insulin dependent diabetes mellitus. Over 90% of the cases of diabetes are type 2 diabetes mellitus. Now, basic pathology insulin resistance, although in the long run patient becomes insulinopenic, insulin secretion is decreased, generally has a late onset, more than 35 years of age. Insulin in circulation is low, normal, and can even be high. No anti-beta cell antibody is demonstrable, unlike in case of type 1 diabetes. Has a high degree of genetic predisposition, they run in families. Now, pathophysiology of diabetes mellitus. Mind it, glucose in the body, they are strong regulator of insulin from the pancreatic beta cells. Now, if there is abnormality in the glucoreceptors of the beta cells, so less insulin secretion will be there and may progress to beta cell failure. This is the number 1 pathology. Number 2 is reduced sensitivity of the peripheral tissues to the insulin, that is down regulation of insulin receptors, shown by insulin resistance. Excess of hyperglycemic hormones, particularly glucagon, and obesity, they all lead to relative insulin resistance. In most cases, however, both insulin resistance and beta cell insufficiency are produced by a combination of genetic and environmental factors. Now, nowadays, the basic pathophysiology of type 2 of diabetes mellitus is shown by ominous octet, where the defect can be in the pancreas due to decrease in insulin secretion. The defect can be in the gastrointestinal tract when the glucose is taken orally from the intestine. Some enzymes are secreted called incretin that include glucagon like peptide 1, GIP, VIP, and others. Now, they also help in the secretion of insulin from the pancreas. So decrease in incretin effect can lead to that. Increased lipolysis can cause hyperglycemia because of gluconeogenesis. Increased glucose reabsorption from the kidney. Decreased glucose uptake from the peripheral tissues. Neurotransmitter dysfunction from the in the case of brain pathology, that can also lead to hypoglycemia. Increased hepatic glucose production can lead to hyperglycemia. Increased glucagon secretion from the pancreas. Now approaches to the drug therapy in type 2 diabetes mellitus. Number 1, by improving the insulin availability, and number 2, by decreasing the insulin resistance. So by improving insulin availability, the drugs are insulin, sulfonylureas, they cause increased secretion of insulin from the pancreas. Meglitinides, DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors, and GLP-1 receptor agonist, that is glucagon like peptide 1 receptor agonist. We will come one by one to each of them. Now today we will be discussing only on insulin. Now these are the drugs, they improve insulin availability, except other than DPP4 inhibitors and GLP-1 receptor agonist. The major limitations of these drugs are multiple daily injection for insulin, hypoglycemic episodes are more with these drugs, except DPP4 and GLP-1. Weight gain, concern about premature atherosclerosis due to hyperinsulinemia. Now, the drugs which overcome insulin resistance are biguanides, that include metformin, the only drug clinically used nowadays. Thiazolidine diones, that include pioglitazone, is the only drug available right now. Alpha glucosidase inhibitors like voglibos. Major limitations in inability to achieve normoglycemia by themselves in many patients, especially moderate to severe. So sekhane kintu one of the drugs from this group is required. Now the drug that has not been mentioned here is SGLT2 inhibitors. They decrease the glucose reabsorption from the kidney and thus help in the control of diabetes. It is a newer drug being used in diabetes and in non-diabetic subjects having heart failure and kidney disease. Now coming to insulin. Insulin was discovered in 1921. Before that, before 1921, a patient having diabetes that was destined to die because no drug was available at till that time. It was Banting and Best who discovered insulin. They discovered insulin in 1921 by demonstrating the hypoglycemic effect of the extract from dog pancreas. Now, pure crystalline form of insulin was obtained in 1926 and the chemical structure of insulin was first delineated fully in 1956 by Sanger. Now coming to structure of insulin. Insulin is a peptide hormone having is a polypeptide hormone having two peptide chains. They have got A chain and B chain. A chain is having 21 amino acids while B chain is having 30 amino acids. They are joined together by two disulfide bonds. Now, before the advent of human insulin, pork and beef insulin were used. Now, these are the subtle differences in the pork, beef and human insulin. In the A chain, 8 amino acid, human insulin they have got threonine. Pork they have got threonine, but in the beef insulin, A chain, 8 amino acid, alanine is there. In the 10th amino acid, again human have got isoleucine. Pork insulin have got isoleucine, but the beef insulin they have got valine. In the B chain, 38th amino acid, human they have got threonine. Pork they have got alanine, beef they have got alanine. So what to be noted here, that pork insulin more or less resemble that of human insulin, and hence they are lesser immunogenic compared to the beef insulin. Now synthesis of insulin. Insulin, as we know, are synthesized in the beta cells of the pancreatic islets. Now, first the polypeptide chain pre-proinsulin is synthesized having 110 amino acids. It's a single polypeptide chain. From that 24 amino acids are first cleaved to form proinsulin. Now this proinsulin is a single chain. From the middle a peptide is cleaved off containing 35 amino acids. This cleaved off peptide is called connecting or C peptide. And after cleaving off, the two amino acid chains, A and B chains, are formed which form insulin. This insulin and C peptide, they are stored in the granules within the beta cells, islets. And when the insulin is released in the body, insulin is released along with the C peptide. Now, regulation of insulin secretion. The insulin is secreted in the body in the presence of various factors. They can be grouped into chemical, hormonal and neural. Now coming to chemical regulator, glucose is the primary principal regulator for insulin secretion. Now what happens when glucose enters, it is by glucokinase, it is converted to glucose 6 phosphate, and by a series of reaction ATP is generated. This ATP causes efflux of potassium by the potassium sensitive ATP channel, ATP sensitive potassium channel. Now that leads to in-drive of calcium, influx of calcium through the voltage sensitive calcium channel, and that is leading to the exocytosis of the insulin from the pancreatic beta cells. So glucose is the principal regulator. Other nutrients that can evoke insulin release are amino acids, fatty acids and ketone bodies. Now glucose that is administered orally and that is administered intravenously. The one which is administered orally, that invoke release of insulin 2 to 4 times than when glucose is administered intravenously. Why? This is because when the glucose is administered orally, incretin hormones, incretins, they are generated. They include GLP-1, GIP, VIP and pancreatogymin cholecystokinin from the gut, which also act on the beta cells of the pancreas, causing insulin release. These are the intestine. Here the glucose is taken up, incretins are formed, incretins reaches the beta cells and causing release of insulin. Number 2 regulators are hormones. We all know that a number of hormones like growth hormone, corticosteroids, thyroxine, they modify insulin release from the pancreas in response to glucose. The more important thing is that a number of hormones, they are produced from the pancreatic beta cell itself. They include insulin, glucagon, somatostatin and others. And there are intra-islet paracrine interaction between the hormones. Now these are pancreatic beta cells. In the center there are cluster of beta cells that comprise around 70% of the cells. They secrete insulin and amylin. Then at the periphery there are alpha cells. These constitute around 20% of the cells. From the alpha cells glucagon is secreted, and in the center some delta cells are there, around 10%. They release somatostatin. There are also epsilon cells and gamma cells. Now this somatostatin, they inhibit release of insulin and glucagon, glutamate. Now this glucagon, they increase the release of insulin and as well as somatostatin, and insulin, they inhibit glucagon secretion. Amylin, another beta cell polypeptide, they also inhibit insulin release by central action. Now neural, the islets are richly supplied by the nerves. Now the adrenergic alpha 2 receptor activation, they decrease insulin release, causing hyperglycemia by inhibiting beta cell adenylyl cyclase. and muscarinic activation by acetylcholine or vagal stimulation, they cause insulin secretion through IP3-DAG pathway, increasing intracellular calcium. Action of insulin. Now insulin, their primary action is to dispose meal-derived glucose, amino acid, fatty acids and store them as a fuel. Now it is a major anabolic hormone. They promote storage of the protein, fat and the carbohydrates. Insulin number 1, insulin facilitates glucose transport across cell membrane, particularly skeletal muscle and the fats. They are highly sensitive to insulin. However, liver, brain, RBC, WBC and renal medullary cells, they are independent of insulin action for glucose uptake. Ketoacidosis interfere with glucose utilization by brain and can lead to diabetic coma. Now again, there are glut transporters, glucose transporters called GLUT, G-L-U-T. Now they are stored in the vesicles, in the cells. Now insulin, they promote the translocation of glucose transporters from the cytosol to the membrane, so that the glucose can be uptaken by the cells, and glucose transporter 4 is highly sensitive to insulin action. Now again, in the action of insulin, inhibits lipolysis and reverse 5 triglyceride synthesis. Now in the diabetic subjects, the fat is broken down by the unchecked action of lipolytic hormone, leading to increase of free fatty acids and cholesterol. Now these are taken up by the liver to form acetyl-CoA. Now in diabetic subjects, because of absence of insulin, acetyl-CoA is not good for resynthesis of carbohydrate, but they are diverted to form ketone bodies that lead to ketonemia and ketosis. Again, the insulin enhances transcription of vascular lipase, lipoprotein lipase, thereby accelerating clearance of the cytomatomes and PNDA. Insulin also facilitates amino acid entry into the muscles and the other cells. Hence, the protein in diabetic subject, protein breakdown is increased, leading to more amino acid in the blood, which are taken up by the liver to form fibrate, glucose and urea. Excess urea is distributed in urine, resulting in negative protein balance. Now, most of the actions that are discussed are rapid or rapid actions. They are internet seconds or minutes. Some actions like increase synthesis of glucose transporter and some enzymes of amino acid metabolism. They involve DNA. They are exerted in few hours. They are intermediate actions. And some measure some long-term effects on multiplication and differentiation of cells. Now, how does insulin trigger hypoglycemia? By their action on liver, muscle and hypoglycemia. In liver, they are increasing the glucose uptake and utilization. They are inhibiting glycogenolysis and glucose output, and they are inhibiting gluconeogenesis. In the muscle, increase glucose uptake and utilization and inhibiting proteolysis. In the hypoglycemia, by inhibiting glucose uptake and inhibiting glycolysis. Now, how does insulin active? Mechanism of action of insulin. The insulin receptors, they are basically receptor tyrosine kinase. Now, it's an hetero-tetramer structure containing extracellular subunit alpha and two transmembrane subunit beta. Now, this alpha subunit, they have got, they are linked by disulfide bonds. Now, this alpha subunit, they have got binding site, and the beta subunit, they have got tyrosine residues. Now what happens when the insulin binds with alpha subunit? The receptor is internal eye. And what happens? There is phosphorylation of the tyrosine residue at the beta subunit terminal. Now this exposes the cation site, causing phosphorylation of the insulin receptor substrate. What happens? Now this phosphorylation of the insulin receptor substrate, they causes a cascade of phosphorylation and dephosphorylation mechanism, causing stimulation and inhibition of several metabolic enzymes or the action of insulin. Again, insulin, they causes translocation of the blood and glucose transporter 4 from the cytosol to the membrane, backed by the ATP. Now, this cascade leads to generation of second messenger PIP3 that also involved in the inhibition and stimulation of several enzymes. Also, via the RAS pathway and MAP pathway, due to the stimulation of the gene, the synthesis and inhibition of several enzymes occurs. Now, after insulin action is over, when the receptor is internalized, either they are degraded in the cell or they can be translocated to the membrane. What will happen? The fate of the insulin receptor indicates on the side where the insulin receptor is located. In liver, most of the receptors are degraded, while in vascular endothelium, most of the receptors are translocated to the membrane. Now coming to the fate of insulin, as you know, insulin is a polypeptide form, so they get included in the gastrointestinal tract if they get orally. So insulin is not taken up orally, it is parenteral. Now injected or that group of bacteria primarily got metabolized in the liver, thus can be metabolized in the kidney and muscles. Now, how integrated basically the disulfide bond is broken up. The two A and B chains are separated and they are metabolized in the constituent amino acids. Carbohydrate of insulin is 5 to 9 minutes. Now, coming to degradation of insulin, before the advent of human insulin, bought and mixed insulin is used. Now, the older commercial degradation of insulin contains 1% of other proteins. That includes proinsulin, other polypeptide, pancreatic proteins, including derivatives. Problem: antireactive. Causing insulin, they are potentially antigenic. They are no longer produced and have been replaced by highly purified hot and insulin, recombinant human insulin and analogs. In 1970s, improved purification techniques like gel filtration, ion chromatography, they are applied to produce either single peak or monocomponent insulin that contains very less amount of other proteins. Now, monocomponent insulin are more stable and are less and cause less insulin resistance. Now, the type of insulin preparations available in the market are: number one thing is bacteria-active insulin. They include insulin Lispro, insulin Aspart, and insulin Tulis. The short-acting insulins are regular or soluble insulin. Intermediate-acting insulin are insulin being sensation, also called lengthy. Neutral protein endon, that is N-based insulin. Also called isoprene insulin. Long-acting, they include insulin glargine, insulin metabolic, and also insulin day-to-day. Now coming to regular or soluble insulin. Number one thing, the solution prepared of the insulin is neutral. Number two, they are unmodified insulin and they are stabilized by a small amount of gene. Now, at a concentration of injectable solution, they are present in hexamers with zinc ion at the center. Now, when they are injected subcutaneously, the
involved are the hexamers and available for action. So peak action is produced only after 2 to 3 hours and the action continues up to 6 to 8 hours. আমাদের ডায়াবেটিক পেশেন্টকে চিকিৎসা করার জন্য দুটো জিনিস দরকার আছে। একটা খাবার পরে যার সুগারটা হচ্ছে সেটাকে কন্ট্রোল করতে হবে, এটাকে বলা হয় মিল টাইম গ্লাইসেমিয়া। সেকেন্ড রয়েছে যখন পেশেন্ট ফাস্টিং স্টেটে আছে তাদের একটা বেসাল গ্লুকোজ স্টেট থাকে, সেটাকে কন্ট্রোল করতে হবে, এটাকে বলা হয় ফাস্টিং গ্লাইসেমিয়া। ঠিক আছে? Now the problem with this type of insulin is that they are short acting, they act only for 6 to 8 hours, so they are taking care of only mean hyperglycemia, not fasting hyperglycemia. Okay, now optimally injected 1 hour before a meal, and very important, regular insulin is the only insulin that can be injected intravenously, not any type of other insulin. Like I don't know, a patient with hyperglycemic insulin, hyperglycemic state, like diabetic ketoacidosis, they are using only soluble insulin, not other type of insulin. Regular insulin is not suitable for providing a low constant basal level of action in the interdigestive period. To overcome the above problem, some long-acting modified or retarded preparations were developed to take care of fasting hyperglycemia. Now, for obtaining retarded preparations, 2 methods are taken up. Number one thing, by complexing the insulin with glutamine, and number two, by using excess of zinc ion, causing precipitation of insulin and increasing the particle size. যেহেতু রেগুলার ইনসুলিনটা fasting hyperglycemia control করতে পারছে না, the modifications were taken up so that the preparation can be long acting. For that, two types of methods were used, either increasing the zinc concentration so that insulin will get precipitated and smaller amount of insulin is released slowly so that it can be long acting. Number two, glutamine was complex with the insulin molecule so that the insulin is released in the circulation slowly. These were two mechanisms by which the insulin solution was made long acting. Now, negative insulin are basically insulin rich substances. There the zinc concentration has been increased. Now, two types of insulin rich substances have been produced. One with the larger particle size, they are called ultra-many, they are long acting, and one with the smaller particle called semi-lengthy, they are short acting. Now, 7:3 mixture of ultra-lengthy and semi-lengthy, they produce lengthy insulin. It is intermediate acting, they act for 12 hours. Now, coming to isoprene or MBBS insulin. Now, these are here basically the insulin molecules. They are complex with glutamine. Now, glutamine is added in a quantity just sufficient to this complex all the insulin molecules. Neither the insulin nor the glutamine remain the free form, and the pH of the solution is neutral. On subcutaneous injection, the complex dissociates slowly to yield an intermediate solution of action. Now, they are mostly combined with regular insulin in 70-30 or 50-50 and injected subcut twice daily. একটা ডায়াবেটিক পেশেন্টকে কন্ট্রোল করার জন্য মিল টাইম গ্লাইসেমিয়া কন্ট্রোল করতে হবে আর ফাস্টিং হাইপারগ্লাইসেমিয়া কন্ট্রোল করতে হবে। তার জন্য two types of insulin required. One is short acting, one is long acting. Now, in this preparation basically, we are combining the MBBS insulin, which is intermediate acting, that act for 12 hours, and combining the regular insulin, which act for 6 hours, 8 hours. So, by combining these two, we can take care of both the fasting hyperglycemia and the mean hyperglycemia. This is what means regimen. Now, coming to human insulin, in 1980s, human insulin was produced by recombinant DNA technology by E. coli, by yeast, and by modifying enzymatic modification of porcine insulin. In USA, what insulin are now used. but it is still available in UK, India and the European countries. Although in India, human insulin and analogs are commonly used. Now, human insulin is water soluble. They are likely having more active substances absorption earlier and more defined peak concentration and slightly shorter duration of action compared with formulation and the big insulin. Now, also modified like that of other insulins, they can also be modified to isolate and lengthy preparations. Now, lengthy human insulin is no longer as periodic injection. Now, coming to the insulin analogs. The insulin analogs basically are the modified human insulin by a man, so that they have got an additional pharmacokinetic advantage. Okay, with having similar pharmacodynamic actions. So, using recombinant DNA technology, insulin analogs have been produced, which are modified pharmacokinetics on some situations, but similar pharmacodynamic like immunogenicity. They have also greater stability and now insulin analogs include short-acting insulin lispro, insulin aspart, insulin bullish, and also long-acting insulin analogs are there. Insulin glargine, insulin decadin, and insulin degludec. These are insulin analogs. The insulin lispro, the B28 amino acid is basically protein and B29 amino acid is lysine. They get reversed. So what happens? The hexamers present in the normal soluble insulin. They are very big hexamers and they dissociate rapidly after some dissociation. So they are ultra short acting. They are resulting in a peak and more defined peak in a shorter period of action. They are injected 0 to 20 minutes before a meal. That is over the minute. The soluble insulin এখন target দিতে হয় আর মানে কি এখন better control of midline glycemia when a meal is taken the peak hyperglycemic peak is going to have a and the peak gastric is outside here. Now the soluble insulin peak of action by 3 hours and action persisted for 6 to 8 hours. So the hypoglycemic chances are low. Now coming to this insulin is pro. Basically, the indicated substitution 0 to 20 minutes. It acts for 3 to 6 hours. The action is soft. So hypoglycemic chances are less with insulin is pro. Better control of hypoglycemia and lower incidence of post-prandial hypoglycemia. Insulin aspart. Now here the B28 protein replaced by aspartate. Now the pharmacokinetic molecular provider is similar to that of insulin lispro. By placing insulin aspart, here the insulin molecule is complex isoprene and a complex insulin isoprene with uncomplex insulin aspart in a 70 to 30 ratio in by placing insulin aspart. Advantage rapid and predictable onset along with intermediate duration of action. Insulin bullish. Here basically at the T3 terminal, lysine replacing asparagine at B29 glutamic acid replacing lysine. Property similar to insulin lispro. Now in type 1 diabetes particularly, insulin pump formula. That is what continuous subcutaneous insulin infusion pump, and in those cases commonly insulin UDCT is used. Insulin glargine, now coming to long-acting insulin analogs. These are long-acting biosynthetic insulin. Here two additional arginine residues are added at the carboxyl terminus of butane, and at A21 lysine replaces arginine. Now this insulin analog, they have got acid, they are soluble in acidic pH. Now when injected subcutaneously, they come in contact with the neutral pH. They precipitate. A depot is created, prompting the protein insulin released slowly. Because of this, it becomes long acting. Duration of action is around 24 hours, and that has to be injected once daily. Because of acidic pH, it cannot be mixed with any other insulin preparation. Now, it is suitable for once daily injection to provide background insulin action. It takes care of only fasting hyperglycemia and has to be combined with other short-acting insulin to take care of the main hyperglycemia. Fasting and interdigestion blood glucose levels are effectively lower. Advantage: lower incidence of nighttime hypoglycemia. Insulin natively, they are milestone of fatty acid. It attaches the amino group of glycine at P29. Now what happens when they are injected subcutaneously? Albumin, they bind to the albumin and the free insulin is released slowly. So they are long acting. Duration of action around 20 hours. A pattern of insulin action almost similar to insulin therapy, but twice daily activity. Insulin Degludec is an ultra long acting insulin analog. And duration of action around 40 hours. Now, after single daily injection, day-to-day variability of the response, day-to-day variability and risk of nocturnal hypoglycemia are lower compared to insulin glargine. It is also been co-formulated with rapid action insulin antibody, unlike glargine, which cannot be co-formulated with other insulin. Now, side effects of insulin or reaction to insulin. Number one, very important, hypoglycemia. Then local reactions are there, allergy and edema. Hypoglycemia is the most frequent and most dangerous complication. Local reactions, injection is given at the local site related edema and stinging sensation may occur. And very important, hypoxia of the subcutaneous fat, they are located seriously with the older preparation of insulin, but with the advent of newer insulin preparation that has decreased. Allergy, that due to the contaminating proteins, very rare newer insulin preparations. Urticaria, angioedema, and anaphylaxis can be the manifestation of allergy reaction. Edema, in some cases, edema may develop with insulin therapy due to sodium reduction. Now coming to hypoglycemia. Hypoglycemia is the most dangerous complication of insulin therapy. Hypoglycemic episodes are more common in labile diabetes. What we make labile diabetes? Basically, there is an insulin department in the patient. Fluctuate dangerous. Accidentally lost blood. Insulin flags accidentally and lost it over here. Now, these patients are very prone to develop hypoglycemia and it is more common in type 1 diabetes. Now, causes of hypoglycemia, number one, labile diabetes. Number two, following inadvertent injection of large dose. Loss of required to the fluid age, that can be hypoglycemia. Patient insulin needs incredibly less, that can be hypoglycemia, missing a meal, or performing vigorous exercise. These are all the causes of hypoglycemia. Now, what are the symptoms of hypoglycemia? The hypoglycemic symptoms can be divided into two groups. One is antidiuretic symptoms because of sympathetic stimulation leading to anxiety, palpitation, tremor. These are also called warning signs of hypoglycemia. And if একটা patient diabetic না বলি, insulin নেওয়ার পর যদি হাতটা কাঁপে, দরকার পড়ে ঘাম দেয়, মানে সুগারটা কতটা কমে গেছে। আইদার কোনো কিডনি ফ্যাক্টরি খাও, সুগার থেকে বা গ্যাস্ট্রিক ফ্যাক্টরি বিকল্প। So this is a warning sign of hypoglycemia. Dangerous hypoglycemia may ensue if not taken care of properly. Now, the second is neuropsychomotor symptoms. They occur due to deprivation of brain of glucose. Now, what are the diseases? Headache, behavioral symptoms, visual disturbance, hunger, fatigue, weakness, muscular coordination, and can affect hypotension. Generally, antidiuretic symptoms precede over the neuropathic symptoms. called warning signs. Now, in this case, warning signs may not be present. Number one is advanced stage of diabetes, where is diabetic autonomic neuropathy. So, this diabetic system can be absent. Number two is on beta blockers, particularly non-beta blockers. The hypoglycemic warning signal can be marked. And then, when the patient is suffering from frequent episodes of hypoglycemia, that can mark warning signs of hypoglycemia. Now, when the blood glucose level goes below 40 milligrams per second, the patient can have mental confusion, abnormal behavior, seizures, and coma. And if the hypoglycemic symptoms are not taken care of, in case of prolonged hypoglycemia, irreversible neurological deficit. Now, how to treat hypoglycemia? How to treat hypoglycemia? A hypoglycemic symptom, hypoglycemic patient, conscious, we will be giving the glucose orally. We will be able to take the meal. How much? Around 20 grams of glucose orally. For any carbohydrate level, glucose like sugar can be taken. And in most of the cases, symptoms are reversed. Improvement can be treated again. Now, if the patient is not able to take the drug orally or is unconscious, then the glucose is injected intravenously. 15% glucose solution is taken around 50 ml and infusion for 10-15 minutes. Alternatively, in unconscious patient where glucose solution is not available, glucagon can be injected 1 milligram IV. Other than that, adrenaline can be used, but are less challenging. Now, drug interactions. Number one, beta blockers. Two interactions are there. Number one, they are masking the hypoglycemic symptom of hypoglycemic symptoms of insulin. Number one, so that basically hypoglycemia may occur. Number two, they are prolonging the hypoglycemia by inhibiting compensatory mechanism operating to beta 2 system. These are two interactions of beta blockers with the insulin. As I use the mind cortical steroids both in the intractable and metabolic, they increase blood sugar level and can decrease the efficacy of insulin. Acute ingestion of alcohol can cause hypoglycemia by depleting the hepatic glycogen. And finally, lithium hydroxide they can increase hypoglycemia by enhancing insulin secretion from the pancreas. As well as peripheral glucose utilization can be increased. Lastly,